You need to talk loud enough, please.
Okay. So I was asked by Christina apparently to give basically the talk that I give to parents and families when we're telling them about heart transplant and why we're considering it. So this is essentially a talk where we're going to tell you a lot of just the basics about heart transplant, not getting into really big specifics, and certainly not anything the parents need to memorize. Remember, it's more to give them an impression of what goes into the whole process, evaluating and listing for transplant, what transplantation itself is, and what life after transplant. So usually I start by actually just sort of summarizing their child, how we got to this point where heart transplant is a consideration. But after that, we go on to tell them that heart transplant is never a required thing. It's nothing we would ever report and say. The child has to have a heart transplant. It's above the standard of care at all times. It's something that parents really have to want to choose, because it's not just it's not a cure for heart disease in general. It's really just trading one heart disease for another heart disease with a completely different set of problems. It's just that in this case, we think that this set of problems allows a better quality of life and allows a better outcome than the heart disease that we're dealing with. Whenever we sit down to talk about somebody for transplant, we have to take into account whether they are a candidate, because there's definitely kids who can be too sick to be a heart transplant candidate. Certainly in this ICU, we've seen people who we've said, no, it's not going to work. And the reason for that is because unlike other surgeries that we do, where even when we say, well, there's a 10% chance that your child will survive surgery, we're just doing a surgery on that child. And if they don't survive, they don't survive, but it didn't affect anybody else. The problem with heart transplant is that we're dealing with a resource with donated hearts that's so rare and so hard to get that we have a commitment as heart transplant cardiologists, not just to our patient and their heart disease, but to the donor family who's giving this really incredible gift, to make sure that that heart goes to somewhere where it's going to do good, where it's going to achieve. And also we have responsibility to all the other kids who are waiting for this, because we know there's actually a really significant high percentage of pediatric patients who are listed for transplant and die before they reach transplant because of just a real significant limitation in organs. So because of that, we really need to make sure that the patient who we're considering transplant in is somebody who we think is going to survive and do well with the transplant afterwards. And that's why we go through this elaborate workup that takes a long time. We don't just slam people onto the list and say, well, we really want to make sure they're going to do well with it. So what does that workup entail? Basically, to start with, it's a complete medical workup. So we look at the heart disease, we make sure that we think the heart disease really requires transplant, that there's nothing that can get better on its own. There's nothing we can do to fix it in any other way. We look at all of their other organs. So we've got to make sure kidneys work, because transplant, especially the medicines you're on after transplant, which we'll talk about, can be very difficult on your kidneys. So if the kidneys are sick to start with, they're going to only get worse after transplant. We make sure the liver is okay. We make sure your lungs are okay. And basically, because all of those organs can affect your outcome post-transplant, we want to make sure they're healthy enough that we can survive transplant. And we'll consult other subspecialties as needed for all of those organ systems to make sure it's okay. We look at people's neurologic status, not so much because neurologic status is really something we use to guide transplant. We just want to make sure parents know that that's not necessarily going to improve, and know that may, if there's a real neurologic injury in the past, the child is going to continue to have that post-transplant, and they'll grow with that and may not improve at all from a neurologic standpoint. But if parents want to make that choice, that's their choice. It's certainly not something that we would disqualify someone from transplant. So that's part of the medical workup. Everybody who's undergoing a transplant evaluation gets a cardiac catheterization. It's really to measure the pulmonary vascular resistance, so pressure in your lungs, resistance in your lungs. And somebody who's got a long-standing heart disease, the lungs and the blood vessels in the lungs can undergo changes to try and basically squeeze blood through the lungs and force it into that stiff or difficult to fill up left ventricle. And that over time can lead to really significant changes in the blood vessels in the lungs, so that they're really tight. And while this person's heart may be okay at moving blood through them, right ventricle, or the right ventricle can keep up with it. If you take a heart from a donor and put it into a patient, and then say, okay, right ventricle that's pretty much used to pumping against really low, nice, relaxed pulmonary vasculature for its whole life. Now that you've been without blood supply for 4 hours while we were doing the transplant, now pump into this really high resistance, high pressure system, you can precipitate acute and irreversible right ventricular failure that's never going to come back. So that's why we measure things. And you hear us at transplant talk about things like PVR and cath and making sure somebody's ready. So we do a cath to evaluate. We do lots of blood work looking at the organ function like I was talking about, but also looking for evidence of other viral infections. There's lots of viruses that you get, and although you're not actively infected with them, they become dormant inside your body. If you're immune suppressed after transplant, those viruses can reactivate and cause pretty significant disease.
Like CMV?
Like CMV or EBV.
But I had a kid that we transplanted, but he was CMV negative, but the heart he was getting was CMV positive.
Yeah. So that happens. And we just have to know what the status is, because it'll change the way we prophylax people and try to prevent infection.
Right, we changed
from reactivating. So we wouldn't disqualify anybody from transplant for any of these infections, including now probably, honestly, HIV, because treatment is so reasonable for it. But we just want to know what people have so that we can be ready to treat them appropriately post-transplant. One of the other things we look at is something called panel-reactive antigens or panel-reactive antibodies. It's PRA, which I know you guys have all gotten those orders and taken a special form and filled out blood tube. PRA is basically a way to measure all of the different antibodies to human white blood cell antigens. So HLA stands for human leukocyte antigen. White blood cells have all different proteins and carbohydrates on the surface of them. And everybody kind of has a different set of these that they express. It turns out that if you measure those, you can really measure how many antibodies someone has to another organ. And basically recognizing those antibodies are one of the things that can cause rejection, or your immune system tries to get rid of it. So a PRA is basically just a measure of the percentage of antibodies to the overall population of people that you have. And we can use that to make sure that we match an appropriate organ. We don't want to take an organ that you're already making a bunch of antibodies to, because when you put that in, the antibodies are immediately going to recognize it as being foreign and tell your immune system to reject it. So PRA is a way that we measure that risk, basically, of finding a heart that you're not going to be able to accept. So we send that, and we continue to send that post-transplant, actually, to make sure that people don't start making antibodies to their new heart, even if they didn't work before. So we do that workup, and then we have a bunch of other people talk to. We have surgery, evaluate them as a surgical candidate. What sort of other risk factors from a surgical perspective might they have, and whether they're a candidate from that perspective. We have social work do a really detailed social work evaluation to make sure this is a family that's ready to deal with the issues that they need to post-transplant. Included in that is a financial evaluation. Not that we'd ever actually reject anybody from a transplant candidacy for financial reasons, but transplants are really expensive. So we want to make sure that everything is in place for insurance coverage, so that it's all set post-transplant, and we don't have to deal with insurance. In fact, we need insurance approval. The hospital requires us to have insurance approval before we can even list something for transplant. So that's part of this evaluation also. Nutrition will see them and do a complete nutritional evaluation, both from a heart failure perspective and from what their needs will be post-transplant. And pharmacy, basically regime, will see them and do what things are. And all of this workup goes together, and we essentially sit down every Friday morning. We have a meeting as a whole transplant team, so that's transplant cardiology, transplant surgery, social work, nutrition, pharmacy, child life. Actually, everybody comes to these meetings on Friday morning, and we talk about the patients that we're seeing. But when we have a new candidate, we'll actually talk about them in detail with everybody contributing their piece, and we'll gauge whether they think they're an appropriate candidate or not. Assuming we think they are an appropriate candidate, we'll then go to the family and say, okay, we think your child's an appropriate candidate. We are ready to list them for transplant. Assuming the family says, yes, we want to go ahead with this, then we'll list them. So what does that mean? The list is a list of everybody in the country whose doctors have decided they are a candidate and they want to accept offers for solid organ transplantation. It's all the different organs that you can transplant, so kidneys, liver, heart, lungs, and it's divided up by separate work groups. It's administered by a group called UNOS, United Network for Organ Sharing. They're the people who take every donor offer and figure out who it should go to. Well, how do they figure that out? Basically, they maintain priorities on the list. So there's a lot of different things to go into who gets an offer. The first one is your status. So really trying to figure out how sick are you. For pediatric patients, there's three main statuses we use. 1A is top priority status. That's somebody who is on high-dose inotrope infusions or a VAD or ECMO. 1B is a low-dose inotrope infusion, pretty much only. There's a couple of other special pediatric 1B exceptions. So you're pretty sick, but not as sick as the 1A group. And status 2 is a group of patients who are sick enough that if we got offered, if somebody offered us to get her, we would take it for our patient, but they're not in any continuous support. They're not necessarily hospitalized. They could be living at home, just sort of thing. And those are really the statuses we use as a pediatric patient. There's also a hold status we can put people into if they get too sick or if something happens where we shouldn't be taking an organ. So that's status. But there's a number of other things that go into it. Your size. We have to match hearts based on size, because if we took an adult heart for a baby, we'd never be able to close the chest. So it turns out you can go from probably about 90% of somebody's body weight, so a little bit smaller, to about twice their size. You might even be able to push that up more towards 3, but our range that we accept offers for is generally about the kid size to about twice their size. Usually we can fit that into the chest and close the chest adequately. We have to match blood types with some exceptions. For most people, you have to match blood types. If you don't match ABO blood type, so if I'm blood type O, so if somebody gave me an A heart, my body would immediately try and reject it, assuming I have antibodies to other blood types, which most people do. We know that in infants, especially, you can actually mismatch blood types, and they'll tolerate that. Their immune system hasn't revved up this part yet, where it's going to reject based on blood types. And if you implant a mismatched heart into an infant, assuming they're not already making antibodies for it, it's actually going to be something they tolerate for their lifetime. They're never going to start making antibodies to it. Why they can tolerate it is a whole arm of research into figuring out how the immune system works. Right now, we can do ABO mismatch up to 2 years. All we have to do is make sure we check every so often that somebody didn't start making new blood group antigens or blood group antibodies in the meantime. There are other parts of the world that are pushing this. In fact, there's reports of adults who have been ABO incompatibly transplanted in Europe, and in New Zealand has a couple that they reported. So this is something that's sort of evolving. But for everybody else, and for most older children now, we have to match blood types. So you've got how sick you are, how big you are, your blood type. Where you live does matter somewhat. UNOS has an algorithm where they sort of match within a region. So it'll match you within your state. They'll try and keep the heart there, and then it will go out to sort of a region of states around you and see if there's anybody in the status there. And it keeps sort of moving across the country. But they try and keep things relatively local to try and minimize the amount of time, ischemic time, time without oxygen. Ischemic time, just in general, how long we think the heart's going to be out without oxygen is another thing that sort of limits our ability to accept hearts or to take hearts. We know that at about 4 hours, your risk of having significant damage to the heart goes up. Doesn't mean there's anything magical about 4 hours, where after 4 hours, it's going to be really sick, whereas before 4 hours, it's going to be great. In fact, we've had some transplant recently just because there's such a complicated rebuild that we've had significantly longer than 4 hours, but the hearts have seemed to do pretty good. But we try not to take a heart that we know is going to be really long. It turns out that we can get most of the way around the country. Essentially anything east of the Rocky Mountains we can take, and with airplanes sort of having right-of-way out of all airports when we're harvesting organs and ambulances, we can cover most of the country, and we've successfully taken hearts from Texas and Florida and Maine, essentially covering everything. But ischemic time and how long and where your heart is matters a little bit in terms of when you're going to go. And finally, determining your status analysis is just how long you've been waiting. So if you have two identical babies, and one has been waiting a day longer, that baby gets offered the heart first in terms of transplant. So all of those things go into your priority, and exactly how all of those things count and balance against each other is difficult to predict. So it's impossible to actually look at everybody who's listed and try and figure out who's going to get offered next because there's so many different moving parts. But UNOS does it. So basically, after we list somebody, we put them on a list and then wait. How long they wait is completely variable. We've definitely had people who've gotten transplanted within a couple weeks of being listed, including recently. We've had people who've waited 9 months, 12 months, even in high status, because nothing gets offered. So we wait. But assuming we wait and the kid's doing okay, eventually we'll get a call that we get an offer. At our center, surgeons take those calls. It's primarily me who takes transplant calls, and we'll get an offer of a heart. And you'll hear all about it from the UNOS transplant coordinator about where it's coming from, what happened to the person, what does the heart look like on echo, and any other information that's including the antibody status of that heart. So we can see if our patient is already making antibodies against it, or the antigen status of the heart. He then will decide, well, that sounds like a good heart, and he'll either say, okay, we accept it, or no, that's not a match with it. But if he accepts it, sort of starts this whole cascade of other things and moving parts. So we'll let the patient know eventually that yes, we're taking a heart, and that person will get a bunch of labs and a bunch of x-rays and a lot of stuff to sort of lay the a baseline going into transplant for us. And then usually you have to wait. And it'll be a waiting while UNOS coordinates the wires to the outside center. When we go to pick up the heart, a cardiac surgeon from Michigan, it doesn't have to be a pediatric surgeon. It's any CT surgeon from Michigan will go harvest. They'll actually fly out to the center to look at the organ and pick it up. While they're on their way out there, usually our patient is being taken down to the operating room and they'll get lined up and they might get intubated and they'll be put under anesthesia while we're waiting to make sure the heart's coming back. Our surgeon will actually go out and look at the heart in the body of the donor and make sure that it looks healthy and it looks kind of as billed as we expected.
Our surgeon does that?
Our surgeon does that. Or a surgeon from Michigan. He's usually in the operating room, like with our patient, but somebody else will go there. It has happened a couple times where our surgeon just got out, has looked at the heart, and has said, this doesn't look like a healthy heart at all, we should not do this. In which case, he calls back to our center, and we have to go tell our patient, or the anesthesia wakes up our patient, we have to go tell the family, we're really sorry, it was a bad heart. We were excited. We were all excited, but we're not going to tell you.
How many times
Usually
does that
understand
normally
it's pretty,
happen?
what?
How many times does that normally
It's happened twice inside the donor, so 2 out of 70 or 80 probably transplants. So, I mean, rare, but it happens. So we actually warn families about that just so they know that that's a possibility. They're not completely taken by surprise when it happens. But assuming that surgeon thinks it's okay, they'll actually harvest it, what we call it, but they'll take the heart, they treat it with some preservative and essentially put it in the cooler on ice and fly it back to Michigan. At the same time, our surgeon will probably start giving surgery and start, making incisions and cutting down the heart. And somebody who's had multiple surgeries, surgeon's going to want to start as soon as they can because there's going to be so much scarring that they have to dissect through to be able to take that heart out. And somebody like who's just a dilated cardiomyopathy who's never had surgery before, it should be a really straightforward dissection down for our surgeon. And then they wait really until the organ shows up before they actually make incisions. It's all gauging how long it's going to take, with the goal of minimizing the amount of time the heart is without blood circulation. So, the surgeon won't actually remove our patient's heart until the other heart is here in Ann Arbor, and we know it's safe and ready to go. But hopefully, right about the time the heart's arriving, our surgeon is starting to basically cut out that heart. The surgery itself is not that technically difficult. I'm sure a surgeon will argue with me a little bit. But in terms of the things that our surgeons rebuild and do, this is not very major. It's cutting across big vessels. So you cut at the superior vena cava and the inferior vena cava. You cut at the aorta and pulmonary artery. And they basically take a ring around the pulmonary veins because pulmonary veins don't like it if you cut them individually. They get scarred and stenotic. But if just take a cup-of transplant. So you make all those decisions, basically just pull the heart out after the patient's on bypass, take the new heart, stick it in, sew along all those things. So it's basically surgeons sewing vessels that are big, not nearly as small as things they sew in some of the other surgeries we do. It can get a little more complicated if they're rebuilding a Fontan or something like that, but there's more to the surgery than just sort of taking that heart and plugging a new one in. But honestly, in the grand scheme of things, it's not that complicated in surgery. So hopefully surgery goes okay, and then our patient comes back up to the unit as a transplant patient, at which point we sort of start anew. So in the ICU, you guys know, we do things that they're not that different from our standard post-operative patient. We do a few things. Like every patient for transplant comes back up on nitric oxide to minimize that pulmonary vascular resistance that we talked about earlier and help that right ventricle be as sort of supported as it possibly can be for at least the first couple days after transplant, sometimes longer. And it's not so much always just gauging the pulmonary artery pressure, it's just doing whatever we need to support the right ventricle as best we possibly can. They'll be on a varying amount of inotrope drips, depending on what they need. Some people don't need any whatsoever after transplant. They've got a heart that's functioning really well and they do great. Some people are pretty sick after transplant and the heart needs a lot of support. Lots of our patients have chronotropic insufficiency, meaning that their heart is beating inappropriately slow. So we treat that with different ways. We can pace them with pacing errors like we always do. I really like using isoprel or isoproterenol on those patients. It's actually really good. It's inotropic support in the heart. It helps it feel better and do well. So it's a good medicine that we use on transplant patients. A lot more in the past than we do now. We're starting to use it more again. I think it's a good drug. And otherwise, apart from those things, they're sort of maintained like any other post-operative patient. We move them towards extubation pretty quickly, and if they're ready to come off the ventilator, we take them off. We wean things off and de-line and detube them sort of as tolerated as fast as we can. Hopefully that goes well. The only other things that we're doing is we're slowly, after the transplant, starting up their immune suppression to prevent them from having rejection. So patients come back on high doses of steroids, and within the first few days after transplant, we'll start our other drugs. At times, we can sort of blast them with really aggressive immune suppression if we're worried that they're at high risk for rejection off the bat. It's called induction therapy. That's when we give things like Thymolol. But we don't do that automatically on everybody. There are centers who do automatically do that on everybody. But assuming they sort of recover from their immediate ICU cares and their heart's working okay, we sort of get them out of their critical disease and we enter the next phase of their care, which is really just making them sort of hopefully a healthy transplant patient. So things we do are all based on preventing the bad things that can happen to you after transplant, essentially. The first one is rejection. We've talked about it a couple times now, but rejection is simply your immune system recognizing the heart as something foreign, something that's not you, and trying to get rid of it. Multiple different parts of your immune system can cause rejection, and we have to monitor pretty closely for all of them. We start people on medications, maintain them on medications for their entire life to prevent rejection. So steroids are part of it. We do actually try and get steroids off by about 6 months after transplant, so we don't make people are not having problems with rejection. Tacrolimus, which you guys have seen patients on, is sort of our mainstay in terms of anti-rejection. It's a great anti-rejection medicine. It's very well tolerated by most of our patients. It's very good at suppressing your immune system enough to prevent rejection without suppressing it to the point where it has problems with infections. We dose it by trough, which is why we really stick those all the time to draw Tacros in the morning. But it really helps us because although it's pretty well tolerated, it's a pretty narrow therapeutic window. If it gets too high, it can cause really significant kidney injury as well as some other problems. If it gets too low, you're not adequately immune suppressing something. So we get pretty quickly about making sure people draw it at the right time so we know exactly what we're dosing. We also use a couple of other different medicines. Cellcept is one of the ones we usually use a lot of. It's called mycophenolate mofetil is its other name. We use a couple of others called mTOR inhibitors. Those are sirolimus and everolimus, but usually we use some combination of 2 or 3 of those medications to suppress somebody's immune system. When we're suppressing somebody's immune system, you can imagine probably make them more prone to infection. That is definitely one of the things we worry about. We worry about it most immediately after transplant. Right after transplant, we're most worried about rejection. Our immune suppression is at its highest. That's when we're actually probably blocking people's ability to fight infection. And we worry about things like CMV, reactivation and disseminated CMV disease, or fungal infections, things like that. So we watch closely for infections. In the first 3 months after transplant, when we're really at high levels of immune suppression, we do prophylactic drugs to try and prevent those infections. So nystatin, everybody's on. Ganciclovir, everybody who has CMV disease is on. All sorts of antivirals, antifungals, just to try and make sure nobody has reactivation. After our immune suppression starts sort of working its way down a little bit, after several months out from transplant, infection becomes not as big of a deal. It's always more likely in a transplant patient than somebody who wasn't a transplant patient. But really, most of our kids deal with colds that hang on for a little bit longer, but aren't necessarily more severe and putting them in the hospital. They just tend to last more. So our kids are generally snotty all through the winter time because they sort of get one and they don't clear it for 4 or 5 weeks, and then we get another one that goes on. Like I said, the other thing about our immune suppression, particularly tacrolimus, it's hard on our kidneys, so we monitor people for their life for chronic renal disease and renal insufficiency, and try and adjust their levels appropriately based on that. So that's rejection, sort of the medicines that go along with it, issues that can go along with the medicines. A couple of other diseases we worry about. Transplant patients can get something called post-transplant lymphoproliferative disorder, or PTLD, which is cancer that's specifically caused by the immune suppression medications we use. In pediatric patients, it's generally lymphoma. In adults, it can present as skin cancer or different places. It can be hard to diagnose because it can present sort of indolently and not really show itself very easily. But it gets treated, usually with chemotherapy, just like anybody else. Some patients that have experience with it recently aside, for the most part, PTLD is pretty treatable. It is, if we just relax and back down on the immune suppression a little bit and let the patient's own immune system kick back in, it turns out your immune system, besides just fighting infections, probably wanders around your body looking for cells that are abnormal. So if we really back down on immune suppression, usually give a couple chemotherapies, although not usually intensive chemotherapy that you think about with other types of cancer. Usually we can send that PTLD into remission pretty easily. So in kids who get PTLD, generally it's not the cancer itself that kills them if they die from it. It's because we back down on their immune suppression. And suddenly somebody who was adequately immune suppressed and we were preventing rejection is now wide open to rejection because we had to come down on their immune suppression to treat their cancer. We've had experience with that problem here too, certainly. So PTLD is another thing we look for. It happens about 10% of people after transplant at some point in their life. Transplant. Definitely the minority of patients, but enough that we see it. And then the final thing that we really spend a lot of time thinking about as a transplant for transplant patients is something called transplant coronary artery disease or transplant coronary vasculopathy. Transplant patients get a specific disease of their coronaries. Pretty much everybody does eventually after transplant. We don't completely understand why it happens. It's probably an immune-mediated thing too. Unlike adult coronary disease, where adults have heart attacks from atherosclerosis, those diseases present usually as sort of plaques in big coronary arteries. So the big branch is your left main or your right main coronary artery. And those are big enough that you can go in with a catheter and you can balloon it and pop it open, or you can do a bypass surgery to go around it. In transplant coronary artery, rather than being sort of like the trunk, the main part of the coronary tree, it's way out in the tiny branches and the leaves of the coronary tree where it feeds into the heart muscle itself. And slowly, over time, all those tiny little vessels start getting more diseased, and eventually they just get sort of occluded. And if you lose just a couple of those tiny vessels, it's not a big deal because it's such a small part of your heart muscle. But if all of those vessels start getting occluded at the same time, or you lose more and more and more, eventually more and more of the heart muscle is without adequate blood supply, and it gets sicker and sicker, and you have somebody who goes into heart failure, and sometimes just like they presented before they needed transplant. So at that point, we have to start treating them for heart failure. And we do the best we can, but eventually they may need to come up for another transplant discussion for retransplantation. So coronary artery is bad. It's something we don't have a really good treatment for at all. And we watch for it, but there's not that much to it. So that sort of brings us to just what's the survival of transplant patients in general. Right now, if somebody is transplanted and we'll say makes it, if assuming they make it the first year after transplant, make it through their first year after transplant, average pediatric survival is probably about 15 years. For infants, they're more likely to die right after transplant for a number of different reasons. But assuming they make it to 1 year, we actually don't have a good estimation of how their survival is because it's really good. It's something above 20 years after transplant. It could be higher. We just don't. Based on the latest sort of survival of those infants, it looks like they're going to be living for a long time. For adolescents and the young adults, survival is a little bit lower for a number of reasons. Some non-compliance, some just they've already developed some sort of bad cardiovascular issues and early atherosclerosis. The survival may be a little lower, maybe more, like 12 years. That's survival of the heart itself, not necessarily survival of the graft. So those are the numbers we deal with. So we have to tell parents, based on what we have, survival to another transplant is probably something we're going to be looking at. Third transplants have happened really infrequently in the United States. They have happened sometimes, but it's really only about 50 across the country people who've had 3 transplants. And it's usually because by the time you've gotten 2 successive bouts of heart failure and all the sort of comorbidities that go along with transplant, your body's sick enough that you're not a very good candidate for transplant. And so if you look at the sort of survival after transplant, say an infant or a small child gets it in those 15 years and then gets retransplanted in those 12 years, we're talking about 27 years survival before we're probably out. And right now we have to tell parents that, well, we can offer a transplant, we probably can't offer a normal lifespan based on the technology right now. I always said, I think that saying that in 27 years or 25 years, whatever in the future, I'm very hopeful that things like bad technology will advance so much that there's going to be completely new options for a person at that point. So I don't say necessarily you just have to expect 25 years and that's it, but I can't tell the future. So it's not clear exactly what we're going to be able to do. But if you look back to 25 years ago, what we were talking about in terms of expectancy after transplant, we're talking about 5 years post-transplant. So now to be saying, oh, we think we can get you 25 or 30, and then who knows? It's a pretty significant difference. So even without the life expectancy, why we do this is really because we can offer a high quality of life. So even though we might not offer a normal lifespan, when we've studied how transplant patients do after transplant, how they rate their own quality of life, they rate it really, really highly. About the same as somebody who had like a VSD closure, a simple procedure, despite the fact that they're seeing us in clinic, they're taking medicines every day, they're getting heart biopsies to look for rejection. All of those things, they still rated pretty generally good quality of life. And we don't restrict our kids in any way, unless there's something special about them. But we have kids who play football, we have kids who water ski and do everything else we can think of. Our goal is to make sure they have the highest quality of life possible. So, really, that's kind of the talk we give to parents. We give them a big binder of basically everything I just said, plus a lot more detail, so they can go through. Again, it's not to make them an expert on transplant. It's just so they've heard everything that can be a part of their life afterwards, and to make sure that they really understand what they're getting into by going down this path.
Are you able to share how many patients we have transplanted here?
How many patients we follow?
Yeah.
That's me.
We currently follow about 80 patients.
Really?
Post-transplant, yeah.
Age range?
Everybody, I think our oldest right now is 23. We've moved a couple of patients over to adult service recently, but infants through young adults. So, and we've had patients who have definitely outlived our clinic and are still doing fine and moved over to the adult adults. I think our longest surviving transplant patient still is 25, 27 years, something like that. On his first heart, it seems to be doing fine. He's not my patient anymore, he's the adult's patient.
Yeah.
He's still doing good.
Yeah. So we have a patient who's on a VAD right now, the Heartware. Is that patient eligible
listed.
for a transplant?
She is, she's listed for transplant.
Is she?
Yep.
Okay.
What status does that list on that either?
So
One.
in pediatrics, if they're on a VAD, it's a 1A. If you're an adult and you're on a VAD, it's a 1B. Mostly because adults are so, VAD technology is so good for adults that they're not really at high risk for dying suddenly. So adults are deemed VADs to be sort of a lower criteria status, the same as for us, somebody on sort of low inotropes. Kids, because VADs are good, but they're not quite as effective or at least proven. VADs are still a 1A indication, moving to the top of the list. So for this particular patient, she's a 1B.
So with her anatomy, if she would get transplanted, would it be here within our?
It would.
Okay.
So it would be Dr. C and our team would transplant her. The plan to be to recover here immediately post-operatively, but transition
To adult.
basically as soon as she's done with the ICU to adult cardiology.
Okay.
How do you guys determine that, like where?
And somebody who's got really complicated congenital heart disease, where our surgeons are clearly going to be better at doing that rebuild, like somebody who's a Fontan, who is going to be some sort of heart disease that our surgeons have never, that adult surgeons just don't see and don't know how to rebuild, where our surgeons know it really well and can rebuild it. Clearly in that patient's best interest that they're being done here. Talking to Ming,
No, it's
to
never
Rick,
been.
they really prefer to operate in their own operating rooms with their own operating teams, which means they're operating here. So
It's just kind of sluggish.
I think those sorts of patients, people who are Fontans, don't really know.
I mean, this is
They
what I
say
signed
we're
up
better
for.
at taking care of them here than they are on the adult side. We understand their physiology,
Yeah.
we understand the
Okay.
issues that they have. So it doesn't matter what their age is, I think taking care of those patients who are failing Fontans, we're going to do our best at. Once they become just a generic two-ventricle transplant patient, recover for it though, where we don't have any expertise, they can pretty rapidly move anything else. They become a transplant patient just like everybody else.
I have a question. So not like this would happen, but it may. If you know how Ming gets the call to say that there's a heart, and before we send anybody to go look at it, they say like they've done an echo. They say it's not a great match, or they say like the person is HIV positive. Does he make that call to go send him, or does he consult with the family saying this isn't an ideal match?
That's a
Or?
good question. So Ming will make the call and say, yeah, we still accept it based on what he takes into account, and he talks to me sometimes. I mean, we talk together on some cases.
Yeah.
Takes into account who our patient is and how badly do we need to. Is this somebody who's in our ICU and we think, well, they probably have 1 or 2 weeks, and that's the most we can support them, they're going to die in the near future. If that's the case, then maybe we're willing to take the heart, where they say the outside echo is, has moderately depressed function. But we think it's just because of whatever happened to that person, there shouldn't be anything really wrong with heart. It should recover. But we have somebody who said, this person is doing fantastic, we really have no problems, we might be a lot more apprehensive about taking sort of a marginal heart for that. In regards to sort of the other part of your question, like is this person HIV positive or something
Yeah.
like that? So there's a number of different criteria that UNOS deems high risk. IV drug user, even if they don't have any, evidence of any infection, things like that. UNOS will say, well, this is a high risk, it's a high risk donor. And we'll take it in theory, but in that case, we actually have to go to the family and get consent and say, look, this is what we have, it's a good heart, we don't have any known infection in the donor, but the donor's an IV drug user, it's possible we can try to get disease. And we have to get consent. We have to talk about the family, and they have to consent to taking that high risk. They can say no. No, we don't want to take that. But we have to consult on some things with the family. For just function, we can sort of talk about it on our team. We don't have to get the best. We do what we think is best. Any other questions?
Have you had any families that have decided not to do
I've had
transplant?
one family who decided not to do transplant. their
Because
choice.
the heart wasn't ideal.
No, who
Oh, that didn't go
just
through.
decided
Okay.
they didn't wanna, they just didn't wanna go through.
Was it an infant?
It was a small child. I think he probably wasn't in for that time, actually. Really sad that I thought of it, one or two. But that was it, yeah, that would be. Have they had families you've thought about before? Other than this one family, nobody's ever actually not decided to go with it, so. Now, that's for somebody who's got like a myopathy where we say, well, it's transplant or your kid's gonna die in the near future. There are other indications, there's people who have, like Fontans with protein losing neuropathy, where there's nothing that's necessarily gonna be fatal in the immediate near future. We just know that eventually this disease is probably gonna lead to their death, and they're gonna get worse from a transplant candidate. But they have a really significant chance of not doing well at transplant right away up front. That's a much more difficult situation for the patient and the family. Say, well, we don't think your kid's gonna die in the next year, may not die in 5 years, but eventually they're gonna die from this. But if you go through this right now, we'll tell you up front, there's a 20% chance they die immediately after transplant. They just don't make it, and that's a lot to take on.
Yeah.
So we've definitely had some families who have really been apprehensive about going down that way from that perspective. And I can't say I blame them. That's a lot more difficult. But only one family who we said your child has significant cardiomyopathy, they're not going to survive. We've only had one family who said that's, we just don't want to do it.
Yeah.
And it was well thought out. It was not a weird decision. Can't say I necessarily agreed with that decision, but they did what they thought was best for their family. And they were informed and they were smart people.
If the kid has got PLE, does the transplant fix that?
Yeah, we think so. For the most part, it may not fix it right away, but pretty much everybody we know of who survives pretty much goes away. I think there's some exceptions here and there in the literature. I'm actually studying it right now with a bunch of other centers trying to make sure we know the answers to that question. But our experience generally is yes, if you survive transplant and are able to wait it out for several months, PLE is going to go.
Good, everybody? Thanks, Kurt.